I would request mute your mics, please. Then we have Dr. Shamad Fernando. He's a lecturer and a general palliative care physician at the Department of Family Medicine, University of Sri Jayawardhanapura, University, Sri Lanka. He was the president of APHN South Asia. We have Dr. Alan Bernard, who is an academic GP, general practitioner at Cape Town, South Africa. And he's an outgoing chair of the WONCA SIG Cancer and Palliative Care. With this, I would like to first give some housekeeping rules. I'm sorry for this, but please mute your mics. If you have any questions for any of the specific presenters, please add those questions in the chat box. I would ensure that each of your questions are addressed at the end of the session. So to begin with, I'll just upload the presentation of Dr. Scott.
Progress.
While that tech is happening, thank you so much, Shrikant, for really coming to the party. And it's lovely to hear some familiar voices in the room. Jeff Mitchell is there. I heard his voice, and it's lovely to see interested people. It's excellent to have a small dynamic group, and thank you to everybody who's signed in from around the world.
So Dr. Allen, I'll upload your presentation.
Shall I speak first? I've got my presentation to share.
Start your presentation. Dr. Allen, please start your presentation.
Okay, thank you very much. I don't have a great deal to say, except to say it's really wonderful to welcome everybody here, as I said. And I hope that that screen is now sharing. Can you see my screen, everybody?
Yeah, we can see your screen.
Can you see my clinical screen or or the presentation? Does it say WONCA 2023?
Yes. Yeah, WONCA 2023.
Oh, good, because it's good. So here we are, and it's an incredible privilege to have served here. It's been a difficult few years because of the pandemic and difficulty with traveling, but we've managed to do some presentations. Just a very brief moment I'm afraid I'm struggling with my tech myself here. There we are. Let me try again. I'm struggling with my tech more than I usually do. Forgive me. What I will do, can you see that? Objectives, share our vision, review history. Is that right?
Yes, we can.
I've gone off the presentation mode. And just to plan how we're going to work together in future. A moment on how we can secure a vision. We need to support doctors as we all provide palliative care. It's all very well for us to meet, but actually we are all clinicians, which is why I asked to be introduced as a family doctor. I see patients this morning. I was doing some preparation for the day. We enable networks, and this is such a network. The other networks that we're all a member of need to overlap and collaborate. And then we need to understand what the need is in the world so that we really do it well. We need to raise the profile with some advocacy, with individual conversations, and by presenting in conferences, and then educate. And so you can hear the overlapping with elderly care, and Dr. Leon Geffen is another doctor from Cape Town who is at the elderly care special interest group this morning and today in Sydney. And so he and I will be talking about how that might overlap. And the education group with Victor Ng is another group where we will also try to overlap. So in a moment, and in Quebec in 2005, a small group led by Professor Murray and Jeff Mitchell brought us together, and that's where this group began, and it's grown, and you can see the list of meetings, an incomplete list of meetings where we've met, and here we are meeting today. These are some of the outputs that have come out of not this group specifically, but the sorts of people that attend these meetings and feed off each other's energy and knowledge and networks. So this was the most powerful piece of work, the strengthening of palliative care as a component of comprehensive care throughout life's course. And then a wonderful piece of work came out of the IAPCON conference a few years ago, where the Indian Association of Palliative Care and the Academy of Family Physicians of India put together a position paper, and that has been widely quoted around the world as a marker of how we do palliative care and collaborate. And this is the toolkit, which is from the EAPC and used in Europe, but also as a marker, is a very sentinel piece of work. And what we're hoping to do in the next hour, listening to other speakers, is to work out what we stand for, who we are, why we want to persevere, why it's important, where we will meet again, when, and how I can contribute. And by I mean Alan Barnard, but by I mean each of us as well. So that's my brief note of introduction. I hope that we enjoy our time together, and I'm really delighted to be here. Thank you to everybody for coming. Thank you very much. That's all I wish to say.
Thank you, Dr. Allen, for the lovely presentation. We'll now move on to the next presentation, and we will take questions at the end of the sessions, as I mentioned. So, Dr. Allen, can you stop sharing?
Do that. There we are.
Thank you. So next we have a presentation, video presentation by Dr. Scott Murray, sharing the presentation.
Just want to see the
Are you all able to see the screen?
Yes.
Okay.
Good afternoon, it's Scott Murray here from General Practice at Edinburgh University, Scotland, and thanks for the opportunity to welcome folk to this really important WONCA workshop in Sydney. So good afternoon and have a great time. I'm so pleased that the WONCA Special Interest Group in Cancer and Palliative Care, as I used to be many years ago, is re-putting this now, that Alan is taking initiative and Shrikant is taking over in charge, and I'm so pleased that you're doing this, because I think networking is a great thing to do. So what I'd like to do is just spend a moment just sharing my passion, my enthusiasm for the potential of primary palliative care, because I can believe it can deliver palliative care really well in primary care. And then say a word for the potential of networking, which is great. That's why it's so important that workers.
It got disconnected. The audio got disconnected. Audio got disconnected.
Hello, sorry, the audio got disconnected. We cannot hear anything here in the room.
Dr. Shrikant seems to have muted himself.
good thing. Stop again.
Yeah, can you stop it first, because there's no audio coming in.
I'll send Dr. Shrikant a text message and see if he can answer that. There might be something going on.
Let's play this
Dr.
video.
Srikat?
The one uploaded.
Srikat. Yeah. Oh yeah, the screen here. Hello, hello, hello.
Yeah.
I've just sent him a text message. I will try and, I'm afraid I can't control the audio,
Can we
so
check the message?
it'll be coming now. We'll just go back a few minutes.
Okay.
Bear with us, everybody. A little bit of grace. We are doing quite an amazing thing, being in different continents and sitting and listening. So thank you very much for your patience. And we'll be there just as quickly as we can.
So, Dr. Dan, is there some concern about the video?
We lost the sound, Srikant. So can you go back about just about halfway and then start again?
Okay, okay.
And then just, I think you were muted.
Primary care.
Is it audible now?
Audible now. Thank you.
All illnesses get palliative care because we have all patients coming to us as physicians. So all illnesses, whether it's cancer, multimorbidity, organ failure, or frailty, you can see these different trajectories of decline. We have these people as they decline over months and years, not just at the end. Secondly, we have primary care have a great potential to deliver palliative care at all times, early as well as late.
This is gone again.
Gone again. Dr. Srikanth, I think you need to keep yourself unmuted so that we can hear your audio.
All dimensions of the not just physical, but holistic general practice. And the third dimension I'd like to mention is that, of course, we actually know that if we can treat all dimensions of the not just physical, but we're interested in talking about psychological issues, social and spiritual. So we're well positioned to identify and help people early in these needs. The fourth, all behind me here, is all settings. We know the family doctors, general practice at home, in clinics, some we work in hospitals as well. So we can actually reach people in all settings. And the fifth law is all patients. There's primary care in different aspects, different. Sometimes it's history, care, family medicine, general practice, whatever. But we have a great potential as family physicians. And that's why it's so great that you've come to this conference. And that we get this special interest group, I guess that most of us are interested in palliative care. So it's really good to get together and network. And I hope that you'll be able to encourage other WONCA in regional conferences also to regrout people to see what they're doing in the different regions, in the different continents of the world. So I'm just going to spend a moment and change my background just to talk something about networking if I may. So also this slide to highlight now that already there are other networks working. So there are 4 global networks of primary palliative care in the different continents really happening just now, because a number of us as physicians have been attending the sort of regional and global specialist palliative care meetings, because there are such meetings. And over the last number of years, there's a group in Europe, top there you can see, up here, Sebastian. So we started a group at the European level, 56 countries, where enthusiastic GPs from there meet together with and attend the conferences there of specialists in palliative care. So we can go to these conferences, speak and advocate for providing palliative care in the community and tell those specialists what the great opportunities to do it there. And you can see down next, we've got Edmund here, and Chama now chairs the special interest group in the Asia Pacific Hospice Palliative Care Network. So that's a group of enthusiastic GPs, and had a meeting just a couple of weeks ago there, and there are from most countries in that region, new members from Bhutan came in there, and they also meet together and talk about improving palliative care in their different countries, speaking with specialists. But there's also actually for a generalist, obviously, so at WONCA, that region met together, there's people there. And also in the Africa, there's 56 countries in Africa, as there are in Europe. And these 2 people here, he now chairs the Africa Palliative Care Association Special Interest Group in primary care. That's where primary care physicians can come together with specialists to plan and to try to get policies and education so that healthcare flourish in their continent and even competing within their countries to see how they can help each other to do it. The Bruta toolkit, and together with WONCA and the European Association of Healthcare in 2015, we can get to 2019. So this toolkit of how we can move forward. And at the bottom here, this is a group out of Britannia, chairs a Latin American group there of enthusiasts who come together to try to advocate for primary care within palliative care. But now in WONCA, you have a great opportunity to advocate for palliative care within primary care. So I hope you have a great, really important special interest group, whatever you call it, with cancer and palliative care. It started because most palliative care used to be with cancer. Now it's also most comprehensive. So good to have maybe a special group together. You may think about that in the future. But it's great that Dan Monday is going to be speaking as well, and Shama, and there'll be Shrikant and others there to actually understand how the network may go forward. So network among GPs at different levels, what I'm suggesting, and also within network learning within specialist palliative care. And then you can find out that we're in that gap, find the gap between generous care, private care, and specialist palliative care. So have a great workshop. Look forward to hearing about it. I'll maybe see the recording and report for there. And all the very best onwards and upwards. Spend the good news. This good news, the gospel of primary care to the ends there. Thank you.
So after the excellent presentation, now we move on to the next presentation by Dr. Daniel Munde. So Dr. Dan, would you be presenting, or should I upload your video?
Sorry, my internet's a bit unstable, so it might be better to play it
Okay,
as you did with yeah. Thank you.
Invitation to speak about the vision.
Just give me a moment. I'm just uploading. Is it audible? Sorry, is it visible rather?
Thank you for the invitation to speak about the vision of primary palliative care and how it might be developed globally. I'm based in Nepal, where we have developed a model of primary palliative care, and I'm also a member of the Edinburgh Palliative Care, Primary Palliative Care Research Group. In the next few minutes, I want to explore where we have come from primary care and primary palliative care. We'll look at the draft definition of primary palliative care which we're about to develop, and we'll then explore something of the scope of primary palliative care and what are some of the important principles which have been developed as a way of health system strengthening, particularly with integrated disease management. I'll use our projects in Nepal to illustrate some of these issues. And finally, we will look at the ongoing work to define the scope of primary palliative care internationally. This group is probably very familiar with much of the global landscape of primary care from Alma Art for 45 years ago, and the starts of primary care development in the Sustainable Development Goals, the Standard Declaration. The current moves through the operational and measurement frameworks for industries. The first move towards universal availability of palliative care was probably in 2007 WHO Public Health Strategy for Palliative Care, echoing Alma Arter's strapline palliative care for all. This identified 4 areas for the work: policy and a need for national plans for delivery of funding, education and training for the work of this and then moves to implement the policy practically, and then finally focusing on medicine availability. Later iterations also included research as a big aspect. The strategy identified the need for delivery by private specialist healthcare professionals, although it did not specify private care. It did, however, rightly point out that the majority of care is given in the home and the community by lay carers. The next milestone for palliative care was the 2014 World Health Assembly Declaration, strengthening palliative care as a component of comprehensive care. This was as a result of much advocacy of the palliative care global health community, and did in fact recognise the central role of primary care in the delivery of palliative care. Palliative care was recognised as an aspect of chronic disease management, health promotion, disease prevention, treatment, and rehabilitation of both the Sustainable Development Goals and the Astana Declaration, and is contained in the operational and measurement frameworks, although not.
So Dr. Dan, I guess the recording is very muffled. So is it possible that you can present it live? Because a lot of our participants would prefer if this were presented live. Would that be possible with you?
Okay.
Yeah.
I'll try to do that.
Yeah, thank
I'll
you.
try
Thank you
to.
so much. I'm just
Um,
I'm stopping the presentation.
Hang on a sec. Yeah, I did a recording because from Nepal, it's quite.
Your sound is particularly good, Dan. So if you are able to share the screen, I think, and just skip to that slide that we got the gist so far.
Yeah.
That you've got very good sound now.
Right. I guess if I do present of you, do you see?
Thank you for the invitation to
notes as
speak
well?
about the
Hang on a
vision
minute.
and goal of primary palliative care. For the next few minutes,
I don't know how to do it without the sound coming in.
Well, just play it. It's playing beautifully. Just hit it.
Okay, hang on a sec. Let's just go.
This group is probably very familiar with much of the global timeline of primary care from Alma Ata 45 years ago.
Does the sound good, everyone?
Yes.
Good, thank you. Let's go. We'll go.
This group is very familiar with much of the global timeline of primary care from Alma Ata 45 years ago, and the stops and starts of primary care development until now, through the Sustainable Development Goals, the Astana Declaration, and current moves through the operational and measurement frameworks and indices. The first move towards universal availability of palliative care was probably in 2007 with the WHO Public Health Strategy for Palliative Care, echoing Alma Ata with its strapline, Palliative Care for All. This identified 4 areas of important work: policy, the need for national plans for delivery and funding; education, the need for training of the workforce and the public; and then moves to implement the policy practically; and then finally focusing on medicine availability. Later iterations also included research as a 5th aspect. The strategy identified the need for delivery by non-specialist healthcare professionals, although it did not specify primary care. It did, however, rightly point out that the majority of care is given in the home and the community by lay carers. The next milestone for palliative care was the 2014 World Health Assembly Declaration, strengthening palliative care as a component of comprehensive care. This was as a result of much advocacy by the palliative care global health community, and did in fact recognise the central role of primary care in the delivery of palliative care. Palliative care was recognised as an aspect of chronic disease management with health promotion, disease prevention, treatment and rehabilitation in both the Sustainable Development Goals and the Astana Declaration, and is contained in the operational and measurement frameworks, although not in any great detail. 2018 also saw the publication of 2 WHO documents on primary palliative care. These are useful and acknowledge the synergies between primary and palliative care.
but they're limited in expanding on the scope of primary palliative care, and the approach to the issue is mainly from the palliative care rather than the primary care perspective. The next year, a group of us developed a draft definition of primary palliative care, which suggested it is palliative care practiced by primary healthcare workers who are the principal providers of integrated healthcare for people in local communities throughout their life. This was published to stimulate discussion, but this got rather lost in the COVID pandemic 6 months after publication. Of course, primary care professionals is not a straightforward concept. Dodds and colleagues, on reviewing primary healthcare systems in low and middle income countries in the Asia Pacific region, found that a wide variety of service configurations with primary care providers by both physicians and non-physicians, physicians' assistants, nurses, and allied health professionals, such as pharmacists and dispensers. When we say primary care, do we mean professionals or institutions in which primary care is delivered? That could be family doctors or GPs, particularly in high-income settings, who might lead multidisciplinary teams. But in many low-income settings, it may be basically trained MBBS doctors with no postgraduate training in primary care, or care provided by specialists who also provide primary care alongside their specialist work in the community, or from secondary, tertiary, or even quaternary sites. But let's put those issues on one side for now and remind ourselves of Barbara Starfield's attributes of primary care. First contact, continuity, comprehensiveness, and coordination, with additional attributes: family-centeredness, cultural competency, and community orientation. Many of these attributes are shared with palliative care, particularly continuity, coordination, patient and family-centeredness, and community orientation. And to this, I would add communication, which is a central and fundamental aspect of all healthcare, but particularly primary care and palliative care. We can go back to Balint and Cicely Saunders 60 years ago to explore the history of communication within both disciplines. So our definition went on: primary palliative care includes early identification and triggering of palliative care as part of integrated and holistic chronic disease management. This links palliative care into the comprehensiveness of primary care. First response and continuity enables early identification for palliative care. Palliative care adds the holistic into integrated chronic disease management. Holistic integrated chronic disease management links into primary care-led NCD management as set out in the Global Action Plan for NCDs. And it also links into Sustainable Development Goal 3.4, committing to reduce premature deaths from NCDs through integrated chronic disease management. This is where I believe palliative care can add value by enabling skills such as patient-centeredness and communication, which are vital to the whole of chronic disease management. One of the challenges to universal health coverage and integrating chronic disease management is the lack of professional skills due to poor training and support, leading to poor quality care, which needs to be urgently addressed, particularly in low and middle income countries. One of the weaknesses, I believe, in frameworks like the NCD Global Action Plan is the rather naive assumption that NCD management can be achieved through developing guidelines and protocols. This isn't sufficient. It also requires fundamental skills like good communication and patient-centered approach with continuity and complex problem solving. So this brings us to the final part of the definition: palliative care strengthening professional capabilities in primary care. And we were thinking indeed communication, patient-centeredness, the importance of continuity and complex problem solving. There is, however, little clear evidence for how palliative care strengthens professional capabilities, so I think this is an important area for further research. So integrating palliative care into primary care should strengthen professional capabilities. And I've also added compassion. Compassion, defined as cognitive awareness and recognition of suffering, empathy, and action to alleviate suffering, has recently been explored and discussed in a series of consultative forums called Compassion Rounds. There is increasing recognition globally, including within WHO, that compassion is essential to achieving universal health coverage. Palliative care can be a vehicle to teach and encourage this. Palliative care advocacy is often made through highlighting the level of need globally, a pain-free dignified death as a human right, and that palliative care is cost-effective. In addition, advocates point out that governments should be held to account for their 2014 commitments. However, this can lead to a view that palliative care should be bolted on to other aspects of universal health coverage. Conversely, we can promote an integrated approach, palliative care as part of integrated chronic disease management in the primary care setting. All of the previously mentioned advocacy challenges apply, but in addition, we can stress how palliative care training and practice can enhance primary care practitioner skills. With limited resources, I don't think that taking a bolt-on approach will suffice to have palliative care included properly within universal health coverage, despite international commitments. But if we can show that it adds value, palliative care might have a chance. Finally, primary palliative care should be developed with the perspective of the three building blocks of primary health care. Primary care with its public health functions, multi-sectoral policy, and action and community empowerment. Its development can be effected through a community-orientated primary care approach. I'll just illustrate that with my experience in Nepal. Nepal has a well-described primary care system centering on district hospitals and surrounding village health posts, which are staffed by mid-level workers. The national strategy adopted in 2017 commits to primary palliative care in rural areas and specifies how it can be achieved. One generalist doctor, preferably an MD GP, and one nurse should have some training, although that's not specified. Their role should not just be in the hospital, but also supporting community staff in health posts. All other staff should receive some training, including those in primary care centres and health posts. The strategy also sees a central role for female health volunteers who are responsible for a small area and know their communities well. Also, the strategy envisages community involvement, increasing health literacy for palliative care in the community with groups and schools. SUNITA is a 3-year project to define and research how the strategy for rural areas can be realised. We are midway through at present. This is the model map with the healthcare development through training and mentorship in red on the left, FCH fees in the centre, and community involvement on the right. We are working with schools and community groups to raise health literacy and to build on caring practices to develop culturally appropriate, compassionate communities. We hope after 3 years to have an evidence-based model based on community-orientated primary care principles, which can then be rolled out. The Green Pastures Palliative Care Unit, which is a clinical training and research resource centre for West Nepal, is where the project is operating. This was opened in 2021. Female community health volunteers mostly work in maternal and child health with mothers groups. When we told them what we were doing, they were keen to learn, saying, "We are asked what to do for people with chronic illness, but we don't know." For health professionals, we blend classroom and distance learning. We bring the health post and district hospital staff together to learn and to form a network. We have translated SPICT LIS for identifying people with palliative care needs into Nepali, particularly for mid-level workers in health posts who don't study in English. The SPICT LIS is laminated and is kept on the record trolley for easy access during ward rounds in a district hospital. We've also translated and Nepalized the palliative care toolkit as the basic text. Here are participants using the toolkit to explore how to manage cases presented to them. Communication skills training is central to our programme and well appreciated by the mid-level health workers who've not had such training before. And this is our distance learning suite at Green Pastures Hospital. We've provided equipment to our partner district hospitals too. So we provide ongoing training with the aim of forming a community of practice for palliative care. So after a canter through some of the principles and an example, where do we go now? Well, in June this year, we had a global meeting linking 4 regions with special interest groups in primary palliative care. We explored the scope of primary palliative care and some of the challenges which are shared across regions. Through this process, we hope to develop a consensus statement for primary palliative care, covering its definition and scope, and to provide resources for regional and local development. Our next event is a webinar to take things forward, and we would encourage WONCA colleagues to join in and be part of the process. It's time to make primary palliative care as part of universal health coverage a global reality.
Thank you, Dr. Dan, for an excellent presentation and running us through the facets of primary palliative care and how palliative care can be integrated into, primary care and some of the challenges that people face when dealing with, primary palliative care. Next, we would now like to move on to the next presentation by Dr. Shamat. Dr. Shamat, would you be presenting from your end?
I'm a bit under the weather, Shrikant, so it will be great if you can play the video.
I can upload your presentation.
But let's see,
Oh,
if it is audible still.
Sure. I'll do that. Just give me a moment.
Just so we can use the time well, just to say thank you, Dan. I put a comment in the box in the chat room to say how wonderful it was to see how the palliative care thinking really ripples out into other parts of care. So that collaboration is happening in Nepal. What a wonderful example. Thank you, Dan.
Hello everybody, this is Chaman from Sri Lanka, representing the primary palliative care
audible?
of the Asian Pacific Hospice Palliative Care.
Very feeble?
And I am
Not very great. It'd be better to hear Shamat if he's able to do that.
Shamat, can you
Can I just say,
Yes, I'll try to do my best.
Shrikant, can I add here? If you I didn't actually do it live. I played my recording on from my PowerPoint. Maybe that's better. If you've got your PowerPoint with your recording there, if you just play that might work better than the MP4.
Oh yeah, sure. Okay, let me try that. Thanks for the tip, Dan.
Hello everybody.
Is it all right now?
Please make it full screen. Yeah.
Is it full screen? Isn't it?
Yes, now it is.
Yeah. Okay, sure.
And we briefly outline the primary to achieve.
We can't hear Shamat.
Yeah. Shamat, I guess
Is
it's
it?
not very audible.
Oh, okay. Did you hear the recording
We could hear the
towards the
first
beginning
few.
and then?
Yeah, we could hear
Uh-huh.
the beginning part of it, but at the end, things got a little muffled.
Oh, okay. Let me try again, please. An ideal model of primary palliative care would look like, the evidence for its success and failure, and indicators of efficient delivery of primary palliative care. Is it? So what is the goal of integrating palliative care within primary care?
So would you be able to present it? I'm sorry.
Yeah,
Would you
yeah.
make
I will.
presentation rather? I'm sorry for this, but yeah.
Yeah, no problem. Okay. Is it visible now on full screen,
Yeah,
or
it's
is it
visible.
still?
It's visible.
Is it full screen or?
It's not
No,
full
it's not full
screen.
screen yet. No, it's not full screen yet.
Oh, not okay. How about now?
Yes.
Yeah, now it's clear.
Oh, okay.
Yeah,
Sure.
now it's clear.
All right. Thank you. So, sorry about the delay, everybody. So this is Chamath again. So I'm going to talk briefly about the model of primary palliative care and then the evidence of its success and failure. So during the presentation, I'll be touching on the primary goal of integrating palliative care within primary care, the 5 key challenges that we aim to achieve through the primary palliative care model, and then the ideal model of primary palliative care itself, and the evidence of its success and failure, and the indicators of efficient delivery of primary palliative care. So first, looking at the goals of this integration, in the transformation from the Alma Ata Declaration in 1978, as Dan said, towards the Astana Declaration of 2018, the United Nations and the World Health Organizations, organization like integrated palliative care within the prime elements of primary health care. So it becomes, it now becomes one of the key responsibilities of primary healthcare workers. So the overall goal of this integration is to achieve universal health coverage, to ensure that the patients and their loved ones have access to the full range of quality palliative care services they need when and where they need them without having to face financial hardships. So talking about the 5 key challenges, we are supposed to deliver palliative care to patients and their families suffering with all sorts of illnesses at all times, encompassing all dimensions of palliative care at all given settings, covering all nations on the globe. So how can we achieve this within a primary care setting? So talking about all illnesses, sorry. So looking at adults, the typical epidemiology of disease globally is such that, many patients would have cardiovascular conditions, followed by cancer, chronic obstructive pulmonary disease, even terminal infections, life-limiting infections such as HIV/AIDS and other chronic illnesses, dementia, frailty. All these constitute the life-limiting illnesses in terms of a patient, in terms of the adult patient population. But now, more increasingly, we see patients with multimorbidity, where many of these illnesses are present in, like many combinations of many chronic diseases together. That's the common presentation in primary care. So moving on to children, the prevalence of diseases that will benefit from palliative care are quite different, as you would see. However, in the GP's role, we all do take care of our adults, children, and the whole range of people, regardless of all these changes. So the basic palliative care management is essentially carried out in the community setting with appropriate coordination with other levels of care. So moving on to all times. So we have, so these are the different illness trajectories. I'm sure you might be, familiar with these trajectories. The trajectory typical of cancer, organ failure, or the dementia, or frailty. So it is quite important or useful for us to learn about these trajectories to be able to give the best of our inputs in primary care at different points in the patient's illness progression. So at certain points, more symptomatic care would be required. At certain points, even disease-modifying interventions would be required. So accordingly, we could plan the patient's care. And more importantly, looking at this diagram, you would see that the palliative care does not just include the care we give the patient from the diagnosis to the death, but even goes beyond, from prevention of the occurrence of a particular chronic disease to providing bereavement care following the patient's death. So it is the whole spectrum of care, the integrated healthcare that the GP is providing while the patient is dwelling in the community. And then moving on to the dimensions of palliative care, the earlier graph, we looked at the patient's physical decline in different chronic illnesses. But here, we also explore the other dimensions of palliative care, which are equally or even more important at certain points. So the above green line shows the physical decline of a patient with cancer, and the lines below show how the social, psychological, and spiritual dimensions are progressing throughout the patient's illness trajectory. So the inputs we give as a GP, a primary care health professional, would be different according to the patient's needs. So this is the graph for cancer, and this is maybe how the patients progress towards their death in organ failure, and finally dementia and frailty. So then we move on to all settings. Palliative care is typically provided in home settings, community, hospice or nursing homes, secondary or tertiary level hospitals, whether it is the inpatient department or outpatient departments. And then even within subspecialties, palliative care is integrated, whether it is intensive care, emergency departments, or even quaternary hospitals. For instance, a patient with chronic obstructive pulmonary disease being managed in a chest hospital, a quaternary level subspecialty hospital. So where does the GP's role come in all of these? So the primary care clinicians altogether, not just GPs, would care for the patients in the home settings, where they might do home visits even, or community settings in the outpatient department. And especially where there is rural care, the GPs also provide their inputs to the hospices or nursing homes within the vicinity or in the catchment area. So these are the typical involvements of a GP, but even going beyond this, they would provide their inputs in terms of the patient's health records and all that to the secondary or tertiary level hospitals or the subspecialty clinical settings. Also, the specialists would also provide their care to the patients in home, community, and hospice settings, but it is always an integrated model, a fashion of care delivery. Then we move on to all nations. Have all of us achieved the universal health coverage in terms of palliative care? So if you would see this important mapping of palliative care development and integration in different countries of the world, the more darker shades in this map indicate countries who have achieved advanced level of integration of palliative care within their public health systems. So, and then there are certain countries with more lighter shades showing there could be only capacity building activity, only isolated provision of palliative care in different loci, or there could be generalized provision, but no proper integration. So those are the different levels of integration of palliative care, which we range from level 1 to 4B. And then again, talking about the universal health coverage, this dot plot indicates how different countries within the 6 WHO regions have achieved universal health coverage. So each dot indicates a country, and each color indicates different continents. So if you would pay attention, for instance, the red dots in Europe, so even within the region, there are countries who have achieved higher levels of integration to countries who have not achieved much. So it applies to the other regions as well, but the dots would scatter within like a longer spectrum. So this may indicate that we might have the resources we need within the same region to share with each other and learn from each other. And similarly, if we do more collaborations between different regions, we may still have a lot of resources to share from. What have really worked in other lower middle and income countries in other regions. So we could all learn from each other and develop the model that suits best in our context. So what does an ideal primary palliative care look like? Well, this would be the highlight of this talk, but there is none. Have you thought why? Well, the globe we live in is like quite diverse in terms of its culture, how the healthcare systems are developed, what their infrastructures are, and what socioeconomic dimensions determine these the care delivery. So we really cannot find one size that fit all different socioeconomic contexts, cultural backgrounds, and all that. So we need to develop a palliative care model that would best suit our country or even region. So then we will look at some examples of evidence for success or failure in different countries who have adopted different models. So then, most important thing, as Scott and Dan highlighted, was that we have to get these 4 things right. Not just one element, but all of them together. All developments should go hand in hand. So the national policies that integrate palliative care into the public health systems, education for all primary care staff, whether the service structure is well implemented, whether it has all the infrastructure to deliver palliative care, and the availability of medicines, mostly the opioids, which are tightly regulated. But then if we only focus on, say, developing the service structure, it might not be as useful because we are not paying attention to the policies which are equally or even more important to bring everybody together towards a common vision. And along this path, I would also like to highlight that we might need to develop sufficient public awareness about what palliative care is, about their right to access palliative care in a timely manner without having to face financial hardship. So some part of the advocacy will be coming from the public's end. So this is an example where all these elements have been well organized, or even they have a vision to develop all elements together rather than focusing on just one element. So this diagram was kindly provided to me by Karine over here. This is the Filipino training framework for hospice and palliative care for health professionals. So they have basic, intermediate to advanced specialty level training in palliative care, but they have not isolated education from all the other elements of what primary palliative care model would be. So they have paid attention to different settings of palliative care provisions, how home-based palliative care would be delivered, how in the community or hospital or specialty services, and how the specialty services would integrate or collaborate with the primary healthcare services. So they've paid full attention to the transdisciplinary approach while also fostering the policies around them. And so they have not only paid attention to the doctors, but also other healthcare professionals. So it is quite a comprehensive training framework, which they are in the process of implementing and assessing its effects. So they are in the process. And then collaboration between specialty and primary palliative care, which we already touched a bit. So that is a very important aspect of success in a primary palliative care model. So this example comes from Switzerland, a European country with advanced level of integration of palliative care within the public health policy. However, like as you would see in the diagram, the different health professionals in different backgrounds, how they interact with each other in delivering the best of care towards the patients. They have a map or a model how to achieve this integration, which is quite important. Sometimes I would also like to mention that in certain settings, there could be some counterproductive or competition between specialist and palliative care, primary palliative care services as to whose job is palliative care really. But then it's everybody's job, but then we need to be sure about how and why we are achieving, how we are identifying what is the remit of palliative care provision within the primary setting or in the specialist setting, and achieve a very collaborative, productive integration. And then moving on to India. So here, as you see, the model of community-based palliative care as a pyramid, right at the top is the specialist centers of palliative care. And then in the middle, you have the family physicians or general practitioners providing primary palliative care. And they have identified in this successful model, right at the base, there is a massive engagement from the community side. So community healthcare workers and community volunteers, they all are providing, they are all involved in palliative care provision in this effective community model. So there, the primary care physician's role will be providing care while also coordinating the patient's care between specialist services right above and the community resources right at the base. And then thirdly, I would encourage any of us, any countries or regions, to define primary palliative care in our respective regions. So this definition, which Dan elaborated on, is coming mostly from a European background. But then we might also need to identify the nuances of the healthcare context and socio-economic backgrounds in different in our respective regions and develop our own model. So this example is from the African region, so not just one country, the region. The primary palliative care special interest group in the African region are in the process of identifying what primary palliative care looks like currently in their region, which is illustrated on the model to the left, and then what they aspire to become. On the right, you find the more integrated, more comprehensive sort of model that they wish to achieve in terms of providing palliative care. Sorry. So finally, there should be evidence-based development of these models and also timely improvements of these models based on audits, even pilots, or even research. So this evidence is very important to inform, select the suitable models, plan, implement the respective models, and also analyze in a timely manner. So this example is again from a country with advanced level of integration of palliative care, in Scotland. It was a GP-initiated model, sorry, where the GPs were able to provide the key information summaries about the patient's clinical data, their preferences, even advanced care planning, the inputs from advanced care planning to the other sectors within the healthcare system. Maybe it could be the ambulance, emergency departments, GP out-of-hours services. So they have developed this key information summaries in a shareable manner so that the care the patient gets is quite integrated and comprehensive. It is well coordinated. So these sort of improvements were only possible because they were doing their research and auditing their practice, and also they are they developed this initiative in 2013 and then developed periodically revised how it was being conducted through their evaluation of this project. Sorry. And then moving on to a few indicators of efficient primary palliative care delivery. If we want to know the evidence, we want to know whether the primary palliative care model is efficient. So these examples are being drawn from the European context. So this is how this map indicates how different countries have achieved early palliative care delivery. So within the region, like the darker shades indicate again like better levels of achievement. That is earlier identification of patients with palliative care needs and referring them to the respective specialist palliative care services and achieving a coordination with these services. And then the second indicator would be whether there are official documents regulating primary palliative care provision in terms of law or policies. And then another important aspect which we all discuss all the time is about how palliative care education is integrated into undergraduate healthcare and medicine curricula, and also how the GPs are being educated on the basics of palliative care. And this graph shows how each individual, countries are geared to deliver palliative care within the primary care context. So how many patients are identified at the primary care level, and whether the primary care physicians are incentivized for delivering palliative care within the primary care setting, and so on. So how much capacity does individual countries have to integrate palliative care? And then finally, the basic take-homes I would like to iterate on is like there isn't a universally applicable model of primary palliative care, but we work with the ultimate goal of achieving universal health coverage in terms of this novel discipline for many countries. And then this model, which we develop, must be sensitive to the disease burden epidemiologies, relevant healthcare, socioeconomic, and cultural contexts within the respective countries. And we need to constantly evaluate and make improvements based on our findings, evaluation findings. And then we also have this potential to learn from each other, considering the resources we have among us. And then it is also important to avoid competition between specialist primary palliative care services or any other different sectors, but promote collaborative efforts to achieve our final goal. And thank you very much. And I would finally also like to invite everybody to join our special interest group on primary palliative care of the Asia Pacific Hospice Palliative Care Network. Thank you.
Thank you, Shamath, for running us through the evidence-based models across the globe, and definitely doing a work like this, like primary palliative care, expanding palliative care in the community is a real challenge. And you've helped us run through this, and I'm sure this would act like a baseline model for us to really work together. Thank you, Shamath. So now we're open to discussions. So, I have already one question in the chat box by Dr. Nandita Mehta. So, Dr. Nandita, would you like to pose this question to the group, rather, because since we have a lot of time? Dr. Nandita? So, Dr.
Yes,
Nandita.
good morning. Good morning, everyone.
Yeah, please,
yeah, I'm Dr. Nandita. I'm heading the Department of Anesthesia in one of the tertiary care hospitals. I was just wanting to know, I am feeling a lot of challenges in my institution because I'm hardly able to start the palliative care model in our institution. What to talk of the community, because there's a lot of difficulty I'm facing in telling my physicians and specialists and other people that what palliative care is for. I just wanted to know, how can we create awareness among these people? What is the way we can attract them to learn about palliative care?
So the panelists, Dr. Dan, Dr. Alan, Dr. Shamath, would you like to take these questions? It is definitely a challenge. I'm sure it's a challenge.
Yeah.
We face it daily. So any of your wisdom, please, Dr. Dan, Dr. Alan, Dr. Shamath, please come forward.
It's a universal challenge that is faced across the world. And it's a little bit about the sense, I think, of people's disempowerment as they are. For argument's sake, if you are an oncologist, you rate yourself against the best evidence and a set of statistics that you share, and you invest a lot, and you invest a lot in the patient and the longitudinal relationship until you are disempowered. And so I think if we can frame our conversations with specialist colleagues in a way that offers something to themselves, to their service, and to the patient. And as Dr. Shamath says, and Dr. Dan, it spreads into non-communicable disease management, into cancer, into all the diseases that we see. There was such a really useful group of slides, Shamath, with the broad spectrum of illness and conditions where we can be helpful as palliative care doctors. So being able to help people, Dr. Nandita, might be a good way to start, and listening to their needs. And perhaps we can take some snapshots from this talk and go from this meeting and take it into our local areas.
Thank you so much. Thanks a lot. But then the thing is, you were right. Like disempowerment is the right word you have used. The physicians, they feel that we are taking away their patients from them by just giving them some, kind of palliation we are offering from the very beginning. It's only in our institution, they only offer refer patients to us for end of life care. And that too, they try to push those patients into the ICU. That is the biggest problem. So there's so many things that we need to learn from this. Thank you so much.
So I have just one point to add here, Dr. Nandita. So yes, definitely when we started off palliative care, it is often a referral for end of life. But it also requires some degree of, understanding from the physicians, your co-physicians, and also some trust that they need to build in you that, yes, you are doing a great job. And the difference that you brought in the patients, that could possibly be a starting point. We don't start off big, we start small and then grow big. And I guess that may be a starting point and departure point for you to really work with your co-physicians. Thank you.
Yeah, thank you. Thank you so much.
Okay, Dr. Shamat, we have a question here from the floor.
Hello, it's more a comment than a question. I am João Carlos from Portugal, João Cepeda Carlos, and I'm a latecomer to this meeting. Sorry for that, because I was sharing another meeting until now, and it was the meeting of non-communicable diseases. And I can imagine that you talked a lot also about non-communicable diseases in your cancer and palliative care special interest group. And we just commented in our group that we should be more together and close collaboration, because there are several groups and special interest groups in WONCA and working parties that share so many points of view, so much content that should work in a collaborative way and more closely. It's not a question, it's a declaration of intent to have some opportunity to close work and collaborative work between special interest group for cancer and palliative care and non-communicable diseases. So I don't know how can we connect, but maybe someone here presentially in this meeting can give me the contact of a special interest group share, and we will connect in the next days to begin our work, collaborative work. Thank you.
Thank you so much, Doctor,
Yes,
because
absolutely.
this is exactly the premise on which we were trying to work on, and we wanted to kind of start off with the networking. And Dr. Allen and I have been discussing on this particular thing that this should be the departure point where we start networking and getting the like-minded people together and to work on our projects together. Yeah, thank you so much.
Yeah.
Yes, Shamat, please tell me.
No, actually, I was just wondering, Shrikant, because you'll be starting to chair the group going forward as well. And then WONCA is also going to advertise their next round of WONCA Collaborative Fund applications call. So that will, we shouldn't just be thinking about one project to put forward. Maybe we can work on more. Like that will be a very good start. Yes.
Okay, I have a comment and a question. Is that okay? All right. So yeah, Doctor, we have a special interest group. Shamat is our lead for the Asia Pacific Hospice Network. Then maybe we can get in touch. So I do appreciate the speakers highlighting the overlapping principles of primary health care and palliative care. By the way, I am Dr. Karen Garcia. I am a palliative care specialist and the incoming SIG or Asia Pacific for Cancer and Palliative Care. So the incoming chair for Asia Pacific. So even the parts of integration of primary palliative care and palliative care was very good discussion on that. And Dr. Dan and Shamat even gave models of care. Perhaps what I wanted to comment is that there is a global primary palliative care is at the time of great opportunity and even threat. There's an opportunity and there's a threat. many nations around the world are committing to universal health care, and but we still do not understand, the importance of primary palliative care and the role of family physicians in general. And there are strengths and challenges here, and each country would have their own strengths and challenges. Perhaps in the WONCA platform, I would just want to hear how we can use that WONCA platform to really push forward primary palliative care. So I've heard defining, giving definitions, that's one. And, what are short-term goals? What do you think are best approach for this? Looking into consideration that each country would have their own unique challenges and opportunities. So I think the chair can answer, or even Shamat and Dan. Thank you.
My name's Jeff Mitchell, and along with Scott, I helped to start the what was then called the International Primary Palliative Care Network. GP and an academic who's retired. I think the best thing that can be done is to use WONCA as a dissemination tool to interested participants who then have their own national platforms that they can utilise. So the European Association of Palliative Care auspiced a process to develop a toolkit to help nations to encourage, to introduce palliative care, primary palliative care into their networks. And there's a paper that was published about 7 or 8 years ago now with that umbrella diagram that was shown on Dan's lecture, yeah. Thank you, sorry. And I was really interested in that subsequent talk to see how you can measure the impact of that by and obviously there has been an impact. There has been a lot of initiatives that have been shown, and in some countries better than others. But I think if people within WONCA have an interest and know that those sorts of initiatives are already out there, and then they can take them back, but they have to work at the local level. I think that's what WONCA can do and does do quite well, is to be a forum of ideas and a forum of activity generation, as opposed to being the leader of a initiative. If the initiatives already exist, then they can be shared between countries. They don't have to be reinvented. So that's what I think WONCA can do. I think the other thing, just while I've got the floor, is that palliative care started in its journey around cancer, because that's where the need was dramatically evident. And to be honest, I think palliative care has nailed cancer. I think we do palliative care really well. What we don't do is to extend that into the end stages of chronic disease. And yet, when you look after chronic disease patients, you know that at some point the end is going to come. And so with a little bit of a shift in thought from a line in the sand saying, palliative care, I've done everything I can, no more palliative care. And usually I've seen in specialist practice that happens about 48 hours before the person actually dies, which is way too late. The idea of planning ahead early and being able to incorporate end-of-life care into standard practice means actually thinking about the possibility that this person isn't going to pull out of whatever crisis they're in at the moment. And we should be preparing for that at the same time as trying to maintain and improve quality of life through the various things that we can do. So it's not that big a shift, but it's a really hard shift for people to undertake because it's not in their mindset to fail. We as a profession, the white knight, coming and rescuing and pulling people from the brink, and that gives us a lot of satisfaction. But the point is that at some point or other they are going to fall off that brink. So are we realistic enough to realise and to acknowledge that our wonderful tools are not going to succeed? And there's a lot of things you can do ahead of time to make sure that at the end there can be a lot of help given to people. Okay, I'll stop there, I think.
Jeff, that was just remarkable, and it took the meeting and this group of people who've come together, and the struggles, and also Dr. The previous question, Dr. Nandita, if I get your name right, you said, how do we do it? And so really that really summarized what we're doing so well. Thank you.
Yeah, please go ahead.
Okay, thank you. I'm Dr. Attakon Raksasare. I'm a palliative care physician in Thailand. My background is family medicine. So Thailand is one country that we have universal health coverage, cover more than 95%, and it's a free of charge. And we include the palliative care into the, also primary palliative care into the universal health coverage. And we see that a lot of people, when they have a universal coverage, something as a free of charge, something they try to push too much to the patients, and patients get suffering and burden from the treatment. Primary palliative care would be a good option to be integrate timely early integration for the also cancer and non-cancer disease. So in Thailand, we integrate with end-stage renal disease with the Kidney Association of Thailand. As a CADICO guideline, they said conservative is a fourth option of end-stage renal disease. So now we have a really good collaboration with end-stage renal. We do an early advanced care plan in all over health section in Thailand. At the first time, at the pre-dialysis, at the time that they give the information which kind of the option of dialysis, and we also talk about advanced care planning when the treatment is getting worse, and between the dialysis session also we have a renew every year to do advanced care planning. It's very easy when we talk further. When the patient get worse, as we predict, they are more acceptable for patients and family members. Easily to say a withdrawal when the time is coming.
Exactly right.
Yes, and also
planting the idea in people's minds, but also the physician. Sorry, planting the idea in the patient and the carer's mind, but also it takes courage on the part of physicians to leave the rescuing mindset to one side and to acknowledge that there is a limit, and at some point that limit is going to be reached. How are we going to do that transition in a way that's effective and compassionate and provides high quality symptomatic management, which is very possible. when the technology fails, which it will.
We are the fag end of our session. I guess we have just less than a minute to go. So I guess it's almost 2:30, 3 o'clock, I guess. Yeah, there. It's almost 2:59 there.
It's actually 4 o'clock.
4 o'clock. Okay, sorry. Sorry.
Yes. But,
So we have less than a minute to go. So
yeah.
I guess we need to now wind up, and a last few words is like definitely the entire premise of our presentation on the workshop today was that we have all our faculties from across the globe present, what they have learned and what they have done across, and also for us to collaborate on projects, collaborate on research, education, service development across the globe. And we intend to have our next presentation, which we would of course send out invites to all of you in the month of January. So we're starting with the first presentation of WONCA SIG palliative care presentation. And we would invite all of you for the presentation and also collaborative work. I have actually put my email ID in the group. So I would request each of you to send me your email ID so that we can start a collaborative work. So Dr. Allen and I will be starting to work with each of you, the NCD group, the geriatric group. So we would like to work across and develop primary palliative care network across the globe. Thank you so much. Dr. Allen, do you have any last words to?
Thank you so much, Dr. Shrikant, Dr. Dan, Dr. Shamat, and Dr. Alan Bernard. Good afternoon, good morning, and what else? Oh, we will have our picture. So you have to turn on your camera, who is in the Zoom. Please turn on the camera, and we will join you for our picture.
While that is happening, it's just I posted the questions, somewhat rhetorically. Who are we? Why do we want to do this? When will we meet again? January. Where will we meet? And we'll meet online, but it's so important to get together in the same room as well when we can. And I'm sad I'm not there, because it just brings back good memories of good conversations and this work. And then how can I contribute? And each of us is at a different life stage. So holding the balance between the work we do with our patients, with our families, and and for ourselves. So take care of each other while we're doing this. We haven't touched on self-care, but that's really something that's very important. Seeing friends and being filled up. That's what the conference does. Thank you so much to Shamath and to Dan and for Shrikant for stepping into the chair. I regard it as very important work, and thank you for doing it.
Thank you. Thank you so much.
Thank you very much, Alan and Shrikant.
Shaman, Dr. Dan, and of course, Dr. Scott, for your excellent presentations. Thank you so much.
Can you open your cameras, please? If you can, if you're able. We're here beside the big screen. You can't see us, but we're taking a picture of all of you together with us. Okay. What about you, Cha?
We do a selfie.
You do a selfie.
This is the palliative care. Then we make a photograph of NCD and palliative care.
Oh, yes, okay.
But we are together. Okay. Okay, now is a selfie for NCD and palliative care.
A selfie would do.